Good afternoon, class. I owe you an apology. I missed out on a couple of cases that I really didn't finish. So what I'm going to do is put this together, put it as a link, send you by email as well as post as an announcement. And again, my apology. I know that many of you are very busy and balance work with your other coursework, and I don't want to have anybody ever feel that they were cheated by me in doing the case studies. What did I miss? Well, pages get messed up and they weren't numbered, and it was my fault. So, mea culpa. Couple of things. If you look in there where we were talking about Estelle, what layers can be affected by her rheumatic heart condition? Well, you can basically see that there's a lot of sites that can occur, particularly with her case. You can have the effect of the bacteria occurring on what would be um, the flaps, but they can also affect to a degree the muscle, especially if they start getting mobilized. You would see this in in basically your presentation um, when you're doing these slides, which is why I'm bouncing around, but I'm not getting the cooperation of my system as well. So you can get an inflammation in the endocardium, and you can end up with problems that will lead to thrombi. And these can go off and start damaging other areas because they will create clots. Okay. You will have the native valve damage. And these vegetations can stay there and they will impede the normal function of the valves. What would probably be important in the treatment of this is that this patient may have to be on certain types of um, treatment for myocarditis. Okay, now you might be sitting there going, what do you mean by that? Well, if you look, what's going to happen is you're going to have an improper amount of pressure. You're going to have someone who's not getting what they really need uh, passing out through those valves. Their valves are going to leak, so they're going to have back pressure. You can have also individuals that are going to have stenosis, so you're going to have also problems with the blood properly getting through from the atria to the ventricles. Okay, so when you have inflammation that's moved from just the valves, but also is irritating the muscle layers, you can see down here you might probably start looking at beta blockers, diuretics, fluid salt restriction, ACE inhibitors, etc. Okay? Now, let's move over to the other sheet, which there were two cases, and I really feel bad about this. I missed them. But again, that's because I gotten my papers mixed up. Um, let's go to case study 3. That's a 65-year-old man, Jerome. He has become unresponsive at the dinner table. He initially had symptoms of indigestion prior to collapsing. That sometimes happens when you start having an MI because the individual, in some cases, they'll actually vomit. They really don't feel well. 911 was called. Family member began CPR within seconds. That's a good thing. We'll get into that in a second. The history of the patient was they are non-smoker, sedentary lifestyle, they're obese, they deny any recreational drug use, there were no meds they were on. The vital signs upon arrival at the hospital, CPR was in process, no pulse, no breathing, unresponsive, cyanotic, O2 sats were at 58%. Now, the patient was pronounced dead within 15 minutes of arrival at the hospital. They had a massive myocardial infarct. Some of the mechanisms that occur there, we can see myocardial infarcts, and what will happen there is basically uh, this unexpected situation, and no one really knows how to deal with it. Now, an MI, you can see the cardiogram, etc., is something that will happen, and it really depends on who responds and how the response is given. The common mechanisms we've almost kind of already dealt with. We've talked about coronary artery disease. We've talked about VFib, AFib, things like that. Okay. What is interesting is that this question brings up another very important point. What is the benefit of CPR? Okay. What you look at today with CPR is something that's quite remarkable. And why I say that is when you have basically cardiopulmonary resuscitation, this is not something that's taken lightly. And really, a lot of people don't realize that you do it until basically somebody tells you to get off, like a paramedic, and also you basically continue it until someone declares the person dead. But what you're trying to do is create the forces necessary to push the blood and keep it moving, okay, as well as attempt to keep ventilation occurring. What is the benefit? Well, let me go back to, and Dr. Gregg does a nice job in this because he starts talking about the various statistics and studies that have been done. Unaccessible automatic defibrillators, okay, AEDs, and usually instead of an MI being an absolute death sentence, okay, we have found that a small percentage survive with good CPR and with the presence of basically these automatic electric defibrillators, okay? But I'll go back further. There was a study done around the early 70s because there were so many people that were dying. Heart attack, boom, call the ambulance, boom. What do we do? Nothing. And the people don't get any CPR because there was no CPR. So they started to train, and I believe this was in the Seattle area. Most of the population, in CPR. And you know what? They actually found after a period of time that the survival rate of a heart attack, an MI, was greater as a result of so many people knowing how to do the CPR. Now, AEDs have now been distributed. There are smaller communities, schools, churches, and such that they will have fundraising just so that they have an AED present. And that is important because that enhances the survival of someone who has suddenly had heart attack. And it can deal with AFib or VFib. Now, there are other causes of sudden cardiac death. There are myopathies, diseased heart muscle, valvular diseases, and electrical inherited heart diseases. Some of those you really can't deal with, until you get them in the hospital to make that clear distinction. But usually, when we're talking about an MI, it's the arrhythmias. They are the main cause of sudden cardiac death. Okay? Now we move from there. Unfortunately, that was kind of a sad story, but let's go to case study number 4. We have an individual by the name of Stanley, and he is a 26-year-old male living in Toronto, Canada. He presents to the hospital with a 1-week history of fever, chills, loss of appetite, chest pain, and shortness of breath. When a patient history is done, He has skin infections from IV drug use. He also has hepatitis C. And he's also had recent dental extraction. His social history, he works in construction. He is married, has 2 children. Upon taking his vital signs, he has a blood pressure of 130/80. Heart rate is somewhat elevated, it's 115. He has a temperature of 39.5, so he's got a low-grade fever, and his O2 sat is 97%. When they do a focused exam on him, what they find is that this gentleman has poor dentition. In other words, basically, he has not been adequately or properly seeing his dentist as he should. Excuse me, I just want to find a few of my notes here. And basically, as a result, he had the dental extraction. He has IV punctures to his antecubital fossa. His respiratory exam shows that air entry is fairly normal to bilateral. No crepitations, no crackles. When they do the cardiovascular examination, S1, S2 is normal with a systolic murmur noted. His skin, though, has petechiae to the skin. He also has splinter hemorrhages to the nails. Wait a minute. Didn't we talk about that with a little bit of problems earlier involving infections to the valves? Yes, we did. And this is a situation where the individual, because of IV drug use, that's where they got the Hep C, because of the poor dental health, they had to have a recent dental extraction, which probably meant that when the teeth were being extracted, or tooth, but I think it's more teeth, you were liberating bacteria into the bloodstream. Also, a 1-2 punch. IV punctures to the antecubital fossa. What he is ending up with is showing up with some signs of what would be abnormal valves, particularly bicuspid, tricuspid. He's starting to show up with these infections. Now, fortunately, this is a little earlier in the scene, which means that there is some hope for this individual from the perspective that they might be able to treat some of the bacterial infection and thereby prevent further exacerbation or intensity of the buildup of the vegetations on his valves. But he's already showing up some evidence. Why? Because basically you're seeing the petechiae and the splinter hemorrhages, which is basically denoting that some of these vegetations have already broken off and are starting to cause emboli or clots in different parts of his body. Okay? Now, that being said, again, I apologize profusely because of my missing a couple of the cases, but don't worry, that won't affect your time or anything else. I'm going to send this out as quickly as I can have it compiled. And again, I hope you have a very nice weekend. Thank you.